Hi, my name is Simone Biscaglia from Ferrara University Hospital in Italy, and today I will talk you about the AQVA trial, that is a randomized clinical trial comparing virtual PCI based on QFR versus angio-guided PCI. So the reasoning behind our study is pretty simple, because we know that post-PCI physiology is related to outcome, but it's not measured during clinical practice, and especially it's not known what to do after a suboptimal physiological PCI results. On the other hand, the quantitative flow ratio, so an angio-based fractional flow reserve estimation, could be easily managed to perform a virtual PCI plan beforehand and not after PCI in order to improve the post-PCI physiological value. And this was actually what we tested in the AQVA trial. As for the study design, we conducted a randomized clinical trial on 300 patients and 356 vessels in 2 different centers. And as for the study population, the major inclusion criteria was the indication for PCI for either ACS or CCS. And obviously we had some exclusion criteria, meaning features limiting QFR computation, culprit lesion on ACS, and the impossibility to acquire good projections for QFR. So the primary outcome of the study was actually the superiority of the virtual PCI plan based on QFR if compared to the angio-based PCI in terms of the rate of suboptimal post-PCI physiology that was measured with the post-PCI blended QFR at the core lab. So basically what we showed is that in the virtual PCI plan we had just less than 5% of patients with suboptimal post-PCI physiology, whereas in the angio-guided arm we have around 15%. So this was a significant reduction of the primary endpoint. As for the main secondary endpoint, we did not show any important and significant differences among the 2 arms as for length of the procedure, number of stents implanted, stent length, albeit we showed a little bit higher delta QFR, so improvement in the QFR value between pre and post PCI in the virtual PCI arm, and a slightly longer procedure in the virtual PCI arm of just a couple of minutes. So I think that the translation in clinical practice is quite simple, because we know that angiography is not enough, and the results of our procedures that are angiographically good for us, they are actually not good for the patient. So we have to try to use these new techniques which are helpful just to achieve the best possible results in each patient. And I think that this is the take-off message of the AQVA trial. I think that the next step should be to test whether this strategy is able to improve the outcome and not only the post-PCI physiological results if compared to angiography-guided PCI, because in this case I think that our practice should really change in all patients undergoing PCI.